So this is a talk called From Asgard to Odin. I don't know if we have any Avenger fans here. I know I am. So we're going to talk about the data coming out of the Odin trial and how it's very encouraging and very exciting. And we'll compare that to kind of what's available or what was previously available. Okay, so the objectives of this talk is going to be to discuss the skin substitute landscape. We're going to discuss the pivotal trials of those skin substitutes, and then we're going to move on to discuss the ODIN trial and where it fits into the patients that we're seeing on a daily basis. So as we know, chronic wounds, diabetic foot ulcers are a serious complication of diabetes. They're difficult to heal and can lead to severe infections and amputations. We know that the traditional standard of care often fails for complex wounds, and this leaves a significant unmet need. So there's a lack of high-quality, large-scale clinical evidence for advanced wound care products, and we'll kind of go through the pivotal data that's available for some of these skin substitutes. So first of all, what is a skin substitute? It's a bioengineered product that's used to cover wounds and promote healing. There's a couple of different types. Cellular or tissue-based contain, of course, living cells, and then acellular contain, non-living cells. And we'll go through each one of these. So cellular-based grafts, there's three major ones, and we're going to go over the pivotal trials for these. First, we'll talk about Apligraft, which is a bilayered, bioengineered. It contains living human keratinocytes, epidermal layer, and living human fibroblasts in a bovine collagen matrix. Then we'll talk about Dermagraft, which is a dermal substitute composed of living human fibroblasts glued on a bioabsorbable polygalactin mesh scaffold. And then we'll move on to talk about the graphic study, which is cryopreserved placental membrane from a human allograft. So it's important to remember this. Now, we're going to see a lot of data, but it's something that's really important is to remember, are we comparing apples to apples, or are we comparing apples to oranges? Because when we're thinking about how should we cover this complex wound, we want to first make sure that we're classifying the wound into its appropriate classification, whether it be UT or Wagner. Is there bone exposed or not? And then is this going to impact which skin substitute we use or not? So first, let's talk about the pivotal Apligraft study. And as you can see, the pivotal Apligraft study was done by Vives, and it's showing here, a relatively high rate of complete closure at the 90-day mark, with approximately 60% of these wounds closing, and you can see a significant difference compared to the standard of care. However, it's really important to remember apples to apples, apples to oranges. So in this pivotal study, the trial-specific inclusion criteria were for full-thickness neuropathic ulcers that failed to respond to conventional therapy. But very important for our ODIN comparison is that these particular wounds specifically had to not include exposed tendon, muscle, capsular bone. So some of these wounds here are not the complex wounds that we're going to be seeing when we're thinking about skin substitutes. Same thing with the Dermagraft study. So again, the Dermagraft study showed that 30% of Dermagraft wounds achieved complete closure, and this was obviously improved in comparison to the conventional therapy group. However, again, right within the study's inclusion-exclusion criteria, you can see there highlighted with the box, patients' ulcers extend through the dermis and into the subcutaneous tissue, but again, without the exposure of muscle, tendon, bone, or joint. So again, these are our UT1, Wagner 1 wounds, where the Dermagraft was shown to be effective. However, it was not studied in these complex wounds with bone, tendon, or deep structures exposed. So how about the graphic study that was done by Dr. Freiberg? So this was a very small study, 27 patients, and kind of had a soft endpoint of 100% granulation tissue. Now, the graphic study did look at wounds that extend down to bone, tendon, or deep structures. However, the primary endpoint for this study was 100% granulation tissue, and also with a secondary endpoint of total closure of being 59%. Both improved in comparison to standard of care. However, again, small number of patients in this particular study. So moving on to acellular-based grafts, I think we're all familiar with the Integra graft. It's a bilayer, acellular. The outer layer is the silicon layer. The inner layer is that porous matrix of bovine collagen, as well as our Epifix, which is dehydrated amniotic chorionic membrane. It's a human allograft with preserved extracellular matrix. And then, of course, our Kerecis product, which we're going to talk a little bit in more detail, which is an acellular North Atlantic codfish So let's talk about the pivotal Integra study. So of course, Dr. Lavery is one of the authors on this study, and we're lucky enough to have him here as well. But this was the founder study. It showed 51% of the patients treated with Integra dermal regeneration template achieved closure after 16 weeks, compared to just 32% in your standard of care group. However, again, this study, the founder study, is looking at Wagner 1 or 2 wounds without exposed capsule, tendon, or bone. So it's kind of a theme here that we're seeing. For most of these skin substitutes, they're being all applied on wounds that do not extend down to the bone, tendon, or deep structures, and we are not looking at these complex wounds. Same thing with the pivotal EpiFix study that was done by Zelen. 92% of the patients with EpiFix achieved complete closure within 6 weeks, compared to only 8% in the standard of care group. But again, this goes back to that same thing we keep on talking about, is the inclusion criteria in these RCTs, where again, the index ulcer was not able to probe to bone, and all of these complex wounds were excluded from this study. So while EpiFix is an improvement over standard of care, we have to remember, is the patient we're looking at, do they have complex wounds, or is this a UT1, Wagner 1, where this may be more appropriate, or at least has been studied in more detail? So that brings us to the pivotal Kerecis ODIN trial, which was done where patients were randomly assigned 1-to-1 to either receive the intact fish skin graft with standard of care, and this study was on RCT, looking at patients that either got the Kerecis graft or standard of care. And healing was assessed as your primary endpoint at 16, 20, and 24 weeks. So like we said, 16 weeks was the primary endpoint, and the key inclusion-exclusion criteria here is that the patients had to have complex wounds with exposed tendon, bone, or joint, and severe ischemia was excluded in this study. So this is actually looking at wounds that most of the other pivotal trials do not look at. So this is an important leap in our understanding of complex wound management, and then skin substitutes to treat that. So as we can see here in the intact fish study in the ODIN trial, at 16 weeks, we saw Kerecis having the wound closure at 44% compared to the standard of care group at 26%, and we see this increases over time. 20 weeks, we have 45% healing, and at 24 weeks, 55% healing compared to the standard care group, 32% and 37%. Now, just to emphasize, how important two things here that are shown on this slide is, one is approximately 50% of these wounds were secondary to amputation. So these patients had a bad infection, and amputation was performed, and then the subsequent wound is what's being treated with this Kerecis intact fish graft, which I think is very common for at least for my practice, and I'm sure for others as well. As this is something we commonly see: open wound, left open. We're gonna vac it and then put on a skin substitute. And how do we make that decision? And also important to talk about expectations, as Dr. Jacobs, Dr. Lavery, and many people have mentioned already, is it's really important to tell your patient what to expect. Here we're seeing complex wounds where patients receiving the standard of care are only healing these wounds 25% of the time in that 16-week period. So this is an important conversation to have with your patient, to tell them that even in the best hands, if you're getting everything you can get, probably about only half of these patients are going to heal this particular wound. So this again is showing this is a schematic representation of the data we just talked about, with 44% healing at 16 weeks compared to the 26% in the standard of care, and 45%, and then again 55% compared to 37% at 24 weeks. So adverse events, again, this is a complex cohort of patients: exposed deep structures, exposed bone, exposed tendon, exposed joint. Here we can see the total infections in the follow-up period. 65% of these patients experienced an infection following the treatment, and about 30% required additional surgical or medical procedures. Again, important to assess this with your patient when you're talking to them, prior to putting on these skin substitutes. This may not be the end for them. The skin substitute may not be the last procedure they need or require. In fact, 65% would develop an infection over the course of this time. So the key take-home here is that in this complex group of patients, Kerecis outperformed the standard of care. However, still with an undesirable outcome of 60 or 55% of patients requiring that did not heal over the 24-week period, compared to the 26% in the standard of care group. So important to take home here is that the Kerecis, or the intact fish graft, had a 70% increase of healing likelihood compared to the standard of care, which is a great leap, and really the best data that we have available as far as RCTs go for these complex wounds with exposed bone, joint, or tendon. So a recent study that was done by Dr. Kirchner looked at a head-to-head study looking at Kerecis compared to EpiFix. And now I only mention this because it's one of the only head-to-heads that we have, and it's showing that the Kerecis graft showed improvement over the EpiFix graft. However, in these particular wounds, these were all punch biopsy wounds. So it's 85 healthy volunteers who had a punch biopsy that was covered with Kerecis as well. So this is kind of going back to that UT1, Wagner 1 type of wound. And here we also see improvement with the Kerecis intact fish graft application. So why is this intact fish graft working, and what are the potential advantages? So important to note that the Kerecis intact fish graft is functioning throughout the healing cascade. So we have faster coagulation rates with the intact fish graft. We have a natural bacterial barrier that's working in our inflammatory stage. And in our proliferative stage, we have rapid fibroblast ingrowth, a faster incorporation, accelerated blood perfusion, and greater epithelialization. And the remodeling and maturation stage here, we're seeing improved tissue quality, and functional outcomes are improving. And lots of this might be due to the three-dimensional structure of the intact graft. Here you can see a graph that's looking at the greater porosity of the intact Kerecis fish graft. And what you can see is on your y-axis is something called optical density. And this is really just a measure of viable skin cells, either fibroblast keratinocytes or human umbilical. So here what you can see is the fish graft is in your orange bar, and your bovine collagen. So this was a study done by Yoon, and here you can see an increased optical density or viable cells within the intact fish graft compared to the bovine collagen in all three, fibroblast, keratinocyte, and also the HUVEC. So does this study represent a paradigm shift? I mean, for me, it really does. When it comes down to how am I going to treat these complex patients with exposed bone, joint, or tendon, I want to be treating these patients with, evidence-based medicine. So the ODIN trial is really the only study that looks at complex bone, joint, and tendon exposed structured wounds here, giving us another option, or at least an option for these patients that has been studied in a rigorous manner. So for that reason, I'm using the intact Kerecis fish graft on these complex wounds in comparison to the other grafts that are available. So to conclude, the ODIN trial provides us robust, rigorous data from an RCT on complex wounds with exposed bone, joint, and tendon, and has demonstrated effectiveness and improvement over the standard of care. More research and more studies are needed here to look at these complex wounds with bone, joint, tendon involvement to compare it to other available skin substitutes. But at this time, this is kind of the best available stuff that we have to treat this. So with that being said, let's all get some coffee and enjoy our first break. Let's make sure that we visit our sponsors who have been so generous. And thank you to all of the speakers for the first session. I think it was really excellent. And we'll meet back here in about 15 minutes. Thank you so much.